Hello, I'm Stéphane Hollon. I'm a vascular surgeon. I'm professor at Paris South University. I have a specific interest in complex endovascular aortic procedures, especially those utilizing fenestrated end branch endografts. So when selecting patients for a branch arch endograft, you have to look at the anatomy very carefully. We've learned from the earlier experience that you cannot treat everyone, and if you want to avoid a high stroke rate or a high mortality rate, you have to make sure that you only treat patients with a proper anatomy. So it means that you need to spend time on the workstation to check that there's a long proximal landing zone in the ascending aorta, that the aortic wall is not diseased, and obviously those patients with shaggy aortic wall should be contraindicated for this type of repair. And with experience, we've actually looked at a niche of patients that can really highly benefit from this procedure. Those are the patients that had a prior ascending repair, a prior open repair of the ascending aorta. So those patients have a long tube graft in the ascending, and this is the perfect proximal landing zone. There is no risk of dilation during follow-up. There's no risk of iatrogenic type A dissection the day of the procedure. And most of those patients, it's actually a long proximal landing zone. Having said that, we actually looked at approximately 70 or 80 patients that had a prior ascending repair for an acute type A dissection, and 30% were still not candidates because the tube graft was too short or was kinked. So when we look at our published experience, the early phase was really not very good with a 15% stroke risk. Then the subsequent patients treated with this technology had a kind of 10% TIA and stroke risk. And recently, I actually looked at a multicentric registry of 70 patients that had this branch endograft following an open repair of the ascending. And in this subgroup of patients, the combined mortality and stroke rate went down to 4%. So it means that we really have a niche of patients that can benefit from this technology, because if you compare that to open surgery, this subgroup of patients requires a reduced anatomy, deep hypothermia, circulatory arrest. So those are quite complex procedures. So for patients that are not fit enough for such an aggressive procedure, I think that the branch arch endograft is something to consider. I think the message is that a patient that had a prior open repair of the ascending aorta following an acute type A should have imaging follow-up, and if they evolve into an arch or thoracoabdominal aneurysm, they should consider a branched endograft if the patient is at risk for a redo open surgery.